there should be a surgeon. And patient, nurse, and laparoscopic devices. Every patient and every stomach is different. Also, we want our patients to trust us on this topic. Of course, we will do our best for our patients. If it is needed, we sew after stapling, but it's not our routine.
I think it's also about the instrument and the quality of our instruments. So we prefer the best of the world. For that reason, we are checking this after finishing the surgery. In the literature, the most common reason of putting stitches after stapling is, I think, bleeding, and the other one is decreasing the rate of possible leakages. But it is shown that there is no difference between putting stitch or not putting stitch about leakage. And also in our clinic, we have an experience that using a good technology staple doesn't change also the bleeding rate. So as Dr. Mehmet mentioned, we prefer to put a stitch if it is needed, not a routine. I think the answer of this question is only one word, the teamwork. Because I don't feel myself alone during the surgery. We attend all the surgeries with 2 surgeons and the other helpers. So we know each other very well. And during the surgery, we don't need to give any comment to each other. Everybody knows what to do. And I think this is the reason of the duration of the surgery. Yes, and the other thing is our volume, I think. We are a very high volume clinic. We are performing almost 200 surgeries in a month, and it's a big experience in all our team. And also the other thing, as always we mentioned, the quality of the instruments is very important to the affecting of the duration of the surgery.
We have a standard, so everyone knows what to do and when, so it makes the surgery time short.
Yes.
We don't recommend over 50 BMIs patients gastric bypass because in our experience we see a lot fat tissue rate inside the intra-abdominal organs. So gastric sleeve is the safest surgery over 50 BMIs, but of course it's not a 100% routine. If the patient has reflux, very serious, so we can do one-way gastric bypass, but first step is gastric sleeve, always over 50 BMIs.
Single port is a technique that can be used in all laparoscopic surgeries. In this surgery method, you are opening only one hole and putting an instrument to the abdominal wall and see the inside with the camera and do all the surgery with the instruments that you put through that one instrument. It can be done in selected patients, I think, because especially in one hole single port technique, belly button's location is very down to the stomach. For that reason, I think with the patients with a high BMI, it will be difficult surgery and it will increase the risk of the surgery. We have not a huge experience about single port surgery because I think we are thinking about the safety first, not the cosmetic first. But in selected patients, yes, it can be done. The other is endoscopic sleeve gastrectomy. It's a new concept, so it's an endoscopic treatment. You are performing a gastric sleeve with stitches inside of the stomach. And in the literature, the recent literature, the weight loss results is very, very low compared to the surgically gastric sleeve. So it is not in our concept for now. But in the patients with a low BMI and in the risky patients with surgical risky patients, yes, it can be an option for us.
Yeah, and also I don't find the single incision one hole in gastric sleeve is not safe, I think, because we do normally 4 or 5 small incisions, small holes. Each hole has some duty, so one of is for liver retraction, one of his assistance, and one of his staple. So just you said before, our priority is not cosmetic. It's first always safe for patients and are comfortable. So if patient is a low BMI, around 35, we can do it. There's no problem. And also endoscopic sleeve, the success rate is very low. And sometimes it's a waste of time and money. And there was a surgery, gastric plication outside the stitch. So it's not done anymore, and also endoscopic sleeve.
Same with it.
Yeah, same, almost same with it, yes. There should be a surgeon, and patient, nurse, and laparoscopic devices. So with our clinic, with our experience in our clinic, endoscopy should be there. It's very important because right before surgery we do endoscopy. It's our routine. Sometimes because in our patient's stomach there's still nutrition food inside, so we have to postpone the surgery. And with revisional surgeries also we need endoscopic evaluation during the surgery. And first endoscopy unit, yes. And laparoscopic devices should be the last technology. It's very important. It's like our hands, and spare parts of all devices, like second laparoscopic unit, second endoscopy unit, and second parts of all our devices, like staple, most of staples, it's very important, and hand devices, laparoscopic devices, it's very important. And it should be last edition of all our surgery devices. I can say this.
Besides your comments, I think an operating room should be ready for everything, every complication during the surgery. So our hospitals that we perform our surgeries is selected ones. We do not do our operations in every hospital, and our surgery team and the helper team and anesthesiologists and the other devices are enough to solve if a possible complication is occur. Sleep apnea, with the other name obstructive sleep apnea, is a life-threatening problem. If a patient has a obstructive sleep apnea, it's very hard to live for him, especially during the sleeping. The oxygen rate, the level of saturation is very low in these patients. And also the most common reason for sleep apnea is the obesity. In our practice, we can see that the patients with obstructive sleep apnea are very healthy in the beginning of the postoperative time. And also in the literature, it has been detected that the success rate of solving the problem obstructive sleep apnea with weight loss surgeries is higher than 95%. In this kind of patients, we should be very careful. We are discussing this issue with the anesthesiologist, and during the surgery, a near monitoring is done with these patients, and if they have a device for obstructive sleep apnea, we recommend them to bring the devices near them and go on to use them for 1 or 2 weeks more according to the symptoms during the sleeping. Then they will remove the device using.
And also we see the difference even the first week. Some of our patients couldn't sleep without even once a day. They couldn't sleep without a device of sleep apnea. So they share their details with a happy mood. This is the first healing disease after our surgeries. Yes, of course, it's important with weight loss, but there's some hormonal changes after our surgeries that they will give a positive healing process after our surgeries.
And we can explain this earlier treating with the hormonal change, I think.
Yes.
Weight gain is a concept, yes, that's true after weight loss surgeries, especially in the long-term follow-up period, 3 to 5 years. In the literature, it's said that 30 to 40% of the patients will gain weight. So we use this sentence, all our patients, that surgery is the first step, but not the whole process. The lifestyle change after surgery is very important because although obese patients have different habits to be obese, they should change these ones. We always educate them to success this concept. For that reason, our follow-up, long-term follow-up is also important. Our nutritionist connection is very important in our patients. But even these, we always have patients that sometimes we are asked by revisional surgeries for some patients that have surgeries in different clinics. Yes, we are performing revisional surgeries. I think our alliance is that we don't advise to do a revisional surgery for patients who have a BMI lower than 35. It's also like a primary surgery, and also the lifestyle change should be done with that patient, because this second chance will be the last chance for the patient. We don't want the same thing after a revisional surgery with a patient who have a weight gain.
Obesity is not curable disease, so our patients shouldn't forget this problem. Even they lose weight, they are still obese. They have to follow the diet rules lifelong. It's very important thing. If they forget they are obese, so it's possible to regain. So I always say to our patients, don't forget that you are obese lifelong.
Gastric bands, with another name, adjustable gastric band, was common treatment in the beginning of the 20s. But nowadays, I think very rare surgical technique, gastric band. So in the literature, it has been detected that only 2% of all weight loss surgeries is with gastric bands, in selected patients, of course. If a patient had a band before, I think the reason of this is the long-term complications of the gastric bands. Most of the patients are suffering from serious vomiting and nausea after band treatment, and another subject is the migration of the band to the inside of the stomach. It's very serious complication. So for that reason, we don't prefer to perform gastric band as a weight loss treatment. But even this, sometimes we can see some patients who have gastric band that was performed before, maybe 10 years ago especially. So this affects our surgery, because during the surgery, first we are trying to remove that band, and it's very important not to injure any part of any other organ. And after this, we are going on the planned surgery, gastric sleeve or gastric bypass. And sometimes another patients attend us to have a weight loss surgery who had a gastric band and removed it before. But even it is removed, and there are a lot of adhesions around the stomach according to the band, and it makes longer surgery time, and it makes us to use different devices for the safety of the patient, and it means to use the operating room for a long time. So yes, we are also experienced about banded patients to revise them. So another part of the question is, why is it a revisional surgery? Yes, it's very different from a primary surgery. It's certainly, even we remove the band during the surgery, or even if it is removed before, it's not same with a primary surgery.
And I think it's old patient surgery, gastric band. I guess in 5 years, no one will do this surgery because of high mortality and high morbidity results. So we have seen a lot of port infection, migration, and lots of another morbidities. So because of this, we don't do it, and we don't want to have gastric bands. Yes.
First of all of our weight loss surgeries are performed in laparoscopy method. It's a keyhole surgery method. So we can always combine these surgeries with also some diseases that can be solved also with laparoscopy. I think the most common one that we combine with weight loss surgeries is a cholecystectomy. If a patient has a symptomatic gallbladder stone that was known before coming and that was detected in our clinic, we can perform cholecystectomy as a concomitant surgeries with weight loss surgery. Another thing is that you asked the reconstructive surgeries, especially plastic surgeries. We don't advise any cosmetic surgery during these weight loss surgeries. The time period that our recommendation is, I think, 1 year, because the weight loss is going on during the 1 year, and if a patient has a cosmetic surgery before they reach their goal, I think this will not be the solution of the problem. So another surgery will be needed also for solving these skin problems. The third one that I want to mention is the hernias, the abdominal wall hernias especially. Sometimes some patients ask us to fix the hernias together with the weight loss surgeries. In all around the world, it's not recommended to fixing any kind of abdominal wall hernia in obese patients, because obesity decreases the success rate of hernia fixation. For that reason, we also don't recommend to treat any abdominal wall hernias together with weight loss surgeries. It's for the health of our patients. We want the best result about any surgery that we do. For that reason, we don't believe a good success will occur if we do together with weight loss surgery and hernia surgeries. This is the reason that we reject to do it.
And also sometimes with hernia, we use a mesh after fixing. So it's not through the same surgery, because the intra-abdominal pressure increases in obesity. After 1 year or 1.5 years would be the best. So we don't have any rush. So it should be minimum 1 year or 1.5 years.
The concept of hiatal hernia is very important in the gastric surgeries, in all gastric surgeries. We are performing weight loss surgeries in our clinic. Sometimes some patients asking us, I have hiatal hernia, what's your recommendation? I think the answer for this question is that we shouldn't make a treatment for radiologic reports. We should treat the patients with symptomatic hiatal hernias. If a patient has a reflux symptoms or other gastric complaints, yes, we can discuss about it. And also in these conditions, the first thing that we do is choosing Roux-en-Y bypass, I think. Because even with a low rate, gastric sleeve is a surgery that will increase the reflux. So with the patients who have hiatal hernia, we don't prefer to do gastric sleeve, we prefer to do gastric bypass. But sometimes also we are fixing the hiatus, the opening in the hiatal area, and then we will go on the other surgical techniques.